Good afternoon, everyone. Thank you for attending today's webinar, Are You a Network? How to Support Survivors in Healthcare Settings. My name is Brooke Meyer. I'm the director of the Institute for Coordinated Community Response, and we will go ahead and get started. A few housekeeping items before we begin. We encourage you to use the Q&A box at the bottom of your screen to ask questions throughout today's presentation. If you'd like to make comments or interact with other attendees or speakers, you can use the chat box for that. And be sure on the blue button that you have selected all panelists and attendees so everyone can see what you've written. If you have any technical difficulties in that instance, you will message only all panelists and ICCR staff will assist. A little bit of background on ICCR before we begin. We were created in 2018 as a program of the Conference on Crimes Against Women. ICCR is a training and technical assistance program that works with rural communities to improve their systemic responses to domestic violence. We provide statewide support to rural Texas communities who are seeking to improve their criminal justice system, collaboration, and responses. We do that by working with teams made up of law enforcement officers, prosecutors, and advocates from several counties across the state each year to take a deep dive into their responses, provide customized in-person trainings, and begin building the scaffolding for a sustainable CCR long after their ICCR year ends. In addition, we also provide monthly webinars like this one and an annual virtual conference to ensure that rural communities across the United States have access to the most relevant cutting-edge training on domestic violence dynamics and collaborative solutions. And while our program is geared towards rural needs through webinars like this, we're able to train practitioners from all over who are committed to eradicating domestic violence. So if you're joining us today, whether you are from a big town, a big city, or a small town, we're so glad to have you with us, and thank you for being committed to this issue. You can learn more about ICCR on our website, instituteccr.org, and I encourage you to sign up for our newsletter there so you can stay in the loop about all of the trainings that we provide throughout the year. We do have a few trainings coming up in January, so you can mark your calendars now. We have a webinar on January 13th on core strategies to reduce systemic inequities for survivors in rural communities. And on January 26th, we will be holding our next bi-monthly Rural Texas Advocates call. So if you are an advocate that serves any survivors in rural Texas, you are welcome to attend that for education, networking, and peer support. We also have a couple of in-person trainings in our current ICCR counties. So if you live near Paris, Texas or Pampa, Texas, please feel free to join us for those. These are completely free for anyone that's interested. They are half-day trainings. Actually, January 12th is a full-day training and January 20th is a half-day training. And those will be eligible for TCOL, MCLE, and any social work or counseling CEUs that you need. You can always find our upcoming events on our website, again, instituteccr.org/upcoming-events, where you can read full descriptions and register. All right, and now I would like to introduce today's presenters. We have with us from the Texas Advocacy Project, Amanda Elkanick Oder, who is the Vice President of Advocacy and Outreach. Texas Advocacy Project is a nonprofit law firm offering free legal services to survivors of domestic violence, sexual assault, and stalking. Amanda has been working with survivors for the past 15 years in varying roles, such as shelter advocate, program director, and policy analyst. These positions have brought an invaluable perspective to her statewide work. She has served on task forces, community planning groups, and committees that are centered on ending intimate partner violence and sexual assault. Bronwyn is the Chief Legal Officer of the Texas Advocacy Project and founder of their Teen Justice Initiative, a program that advocates for teen victims of dating violence. In 2016, Bronwyn was awarded the Texas Access to Justice Commission's James B. Sales Boots on the Ground Award for her legal services work. She has been featured on America's Most Wanted and Court TV as an expert on this issue and has previously clerked at the Family Justice Division of the Travis County DA's office and at Break the Cycle, a nonprofit in DC. She's also served as an officer on the board of Girl Start, which is an organization that empowers girls in STEM. Amanda and Bronwyn, thank you so much for joining us today, and I will let you take it away.
Awesome. Thank you so much, Brooke, and for ICCR for having us today. We are very excited to be doing this presentation for y'all. Let me get to sharing my screen. Hold on one moment. There we go. Okay, cool. Well, I don't really have to introduce myself because Brooke already did a wonderful job introducing me, but we'll go ahead and introduce who Texas Advocacy Project is in case you've never heard of us. And I'll give Bronwyn. Bronwyn, do you have anything that you want to add that isn't on your bio?
No, man, that's a long one. I'm really happy to be here presenting on this topic, especially with my partner in crime, Amanda.
Awesome. Okay, so today what we're hoping to accomplish in our training with you is just to figure out ways, whether you are in the healthcare profession or you're an advocate with a domestic violence organization, or maybe you work as part of some system like law enforcement or probation or parole, how can we engage with the healthcare field to address the needs of survivors? We know that about only 10% of survivors of domestic violence will ever actually enter into a domestic violence shelter. And because of that, we really want to try to meet survivors where they are. And so the healthcare profession is a great space for us to intersect with. And so we're going to give you lots of fun examples and ways to have those conversations and some resources to share. So here's us. We have been working with Crimes Against Women for, goodness, Bronwyn, you probably have been working with them for longer. I've been working with them for about 6 years now. And so, yeah, we're excited to be doing this presentation with you. I'm going to let Bronwyn give you some legal disclaimers because she's the attorney on the call today.
All right, I'll make it painless. I am a lawyer. I am not your lawyer. This is not a great place to ask confidential questions in front of everybody. We, of course, want to be available as a resource, not just to your clients, but to you as well. And honor the fact that we probably have survivors with us on the call. Please feel free to reach out to me via Texas Advocacy Project. We'll share our number at the end, but it's 1-800-374-SAFE. I'll chat that in a second. We'd love to be of help to you, but information we share in this is not confidential and it's not meant to be, personal legal advice to you. Amanda and I are pretty good about using the right pronouns here. We know that interpersonal violence is something that can happen to men and women and anyone else on our gender spectrum. Any gender identity can definitely experience interpersonal violence. We actually know that people who are trans are at a higher likelihood of experiencing interpersonal violence. So it's definitely something that's important for us to be careful about. We'll try to model that. You keep us honest and try to do it as well. We also have a nice copyright disclaimer on here. Amanda and I have borrowed heavily for some really smart people around the country who have information and techniques that we've identified and used and borrowed and liked, and we will always give them credit. We would love it if you were to use our materials in your life. Just please do the same for us.
Awesome. Thanks, Bronwyn. Okay, so I'll kind of go into who Texas Advocacy Project is. If you've never heard of us before, please drop your contact information into the chat box, and we'd love to reach out to you and follow up with ways that we can partner alongside you and your communities to serve the survivors that intersect with your agencies. But Texas Advocacy Project is going into our 40th year. Next month, we start celebrating for the entire year, 40 years of being able to serve survivors across Texas. We have historically been seen as a nonprofit law firm, a statewide nonprofit law firm. In this past year, we've really been able to expand that as we're growing across the state. As our team is growing, we have added a social work department as well, so that our social workers get to come alongside our attorneys and provide those basic needs that survivors might have to help them be more successful in whatever their legal agenda is, whatever their legal options are. So one of the things that's really important for you to understand is that our team at Texas Advocacy Project exclusively works with victims of intimate partner violence, sexual assault, and stalking, and that includes victims of human trafficking and child abuse. We don't have any restrictions on our services, so we don't have income or immigration or recency and violence restrictions, and we don't have a wait list. We do, again, only serve victims of intimate partner violence, sexual assault, and stalking. So that's really the only restriction that we have. We love working alongside organizations like yours and figuring out ways that we can offer these warm referrals. And then as part of my department at the Texas Advocacy Project, which is our advocacy and outreach department. My department does all of the trainings, or most of the trainings. We have attorneys who come alongside us to do those trainings as well. But we do trainings and we go out in the communities and do health fairs, and just again, trying to raise awareness to get survivors connected and linked in with us. Is there anything that I missed on there, Bronwyn, that you'd like to add?
No, I think that's great. I love bragging about TAP. Amanda and I have both been in the movement for a long time. I've been at TAP for 16 of those 40 years, so I'm a super fan.
Okay, so this was our year in review, just a real quick snapshot of how many survivors we were able to serve in 2020. And so just like y'all, we were serving survivors in the middle of a pandemic where we knew that we were going to see an increase in domestic violence, but probably a decrease in survivors' accessibility and reaching out to survivor-centered agencies that can try to get them legal solutions or help or shelter or any type of service that they might need. And so, our agency was no exception to that. We saw kind of like a dip at the first couple of weeks of the pandemic, but we've seen a steady increase ever since then. We've had, I would say right now, we have the highest number of high-risk cases on our caseload that we've had ever. And some of these cases are worse than cases I've seen whenever I've run domestic violence shelters. So I'm not going to get into all the details of all of this stuff right here, but you can see it on your screen. Y'all are the experts as well alongside of us. So these statistics, that a lot of people, about 1 in 3 Texans will experience intimate partner violence in their lifetime. And what we saw is those statistics actually came, the national statistics actually came closer to what we're seeing here in Texas as well because of a result of the pandemic. All right, we're going to show you a quick video and then we'll jump into the content. Trigger warning, what you're about to watch does have some of the survivors that we've served and some of the topics of their cases. And so just a trigger warning before, I want to do like a blanket trigger warning for the rest of this presentation. There might be things that you hear or see. I want for you to make sure that you take good care of yourself and of your own mental health, because there's no way that we can serve survivors if we're not meeting our own needs first. So if you need to take a step away, if you need to go outside, get some fresh air, get a drink of water, use the restroom, please do any and all of those things if you need to.
What is your emergency?
No! Stop! Stop it!
He drugged me by my hair across the living room floor. He tried to break both of my arms.
I feel like my children were ripped from me.
He had told me he would hurt my little brother, he would hurt my mom.
My attorney with the Texas Advocacy Project was able to help me find out strategies and things that we could do in order for me to see my children again.
My attorney helped my daughter to receive a lifelong sexual assault protective order against her abuser, my ex-husband.
I was awarded sole conservatorship. That is the single most important thing that's happened in my life. My son and I are safe today because of Texas Advocacy Project.
All right. So let's take a deep breath, collective deep breaths in, out. We know that this work is hard. Texas Advocacy Project really wants to help to ease some of that burden that you and the survivors that you face every day. So please utilize us as a resource. Let's jump into the content. So let's just first start with, what are the needs of our patients? We know that you are likely, and if you're a healthcare professional on this call, fantastic. We're excited that you're here. You're probably already treating these survivors and these victims. They're already intersecting in your work. So let's talk about what's the prevalence of intimate partner violence. We know, like the slides earlier said, about 1 in 3 women will experience some form of intimate partner violence in their lifetime around the world. Specifically here in Texas, we know that that is also true. So you may have patients coming into your office for a number of things, maybe their annual exam, or maybe they just, their children are having a checkup, or they're maybe they're pregnant and they need to have all of the doctor's appointments visits that you have when you're pregnant. So it's really important for us to start to identify when somebody might not be in a healthy relationship and might actually be in danger. And we're going to give you some really tangible ways to do that.
Yeah, and what Amanda had observed earlier that we've experienced at TAP has been shown to be true universally, that there really is a double pandemic going on. Some people call it a shadow pandemic during COVID-19. So the bottom line is anyone and everyone that can work to address issues of interpersonal violence, whether it be people in the movement, people in the healthcare field, we all need to come together around this if we're going to keep survivors safe.
Thank you, Bronwyn. I'm gonna throw some like statistics at you really quickly because you probably already know this information. We are also going to make this presentation available for you afterwards, so you can always go back and review any of the content in here. But what we know is that each year about 10 million kids are exposed to domestic violence. 90% of those have witnessed abuse in their home. Some of the worst calls that we hear are the 911 calls where we have a child who's calling 911 because one parent has murdered the other parent. The percentage of physical assaults perpetrated against women that are reported to the police annually is about 1/4 of all of those, of all of the types of abuse. So we know that a really small percentage of domestic violence is actually even being captured within our law enforcement statistics. One of the spaces that Bronwyn and I have really focused our efforts in this past year was we strategically met and said, okay, we want to work with all healthcare providers, but even though we are a dream team over here, we cannot serve everybody, right? That's why we need amazing advocates like y'all to partner with the local agencies in y'all's areas as well. But we decided that one of the areas that we really wanted to focus a lot of our resources in was the perinatal space. So the prenatal and postnatal space, when you're pregnant and then right after you've given birth, or maybe you've had a miscarriage, that interim space. We know that survivors are at an increased risk for domestic violence during that time. There's about 324,000 pregnant women that are affected by intimate partner violence each year in the United States.
Amanda, there's that gray bar is at the top again. I don't know if you need to click something. Yeah. While she's looking at that, you know, I'm not a student of statistics. I know we're dropping a lot of them on you, but this is so compelling because what we know is that what Amanda shared, if you're pregnant, you're more likely to experience interpersonal violence. And we also know that if you've experienced interpersonal violence, you're more likely to become pregnant. And you're not usually able to flip statistics like that. So the overlap between these two issues is strong.
So in the kind of continuing on that same space of like pregnancy and intimate partner violence, what we know is about 32% of the survivors that we serve that become pregnant in their relationship, there's been some type of reproductive coercion. When I'm talking about reproductive coercion, things that I'm talking about is maybe limiting somebody's use of birth control or lying about their use of birth control. Maybe they're not allowing them to receive their annual exams, or they're forcing them to do things that they're uncomfortable with. That's what I'm talking about when I'm saying reproductive coercion. Here in Texas, we've heard a lot more about reproductive coercion over the past few months with Senate Bill 8 passing. And so, you know, this is a really important time for us to focus our efforts into the number of women of intimate partner violence who became pregnant unwillingly, or they had an unwanted pregnancy because of that coercion from their partner.
And you all might know this, but we know that many survivors don't. So please help people to identify this, because reproductive coercion is hard to spot.
Yeah. We really do want to go into the numbers that we're showing you, and that we kind of keep going through all these different statistics to highlight how big this problem is. And even in this large number, 1 in 3 Texans and 324,000 pregnant women, what we know is that women of color, and specifically Black women, suffer intimate partner violence during pregnancies and maternal mortality at an increased rate, at disproportional rates than their Hispanic and non-Hispanic white women. We know that Black mothers are about 4 times more likely to die than white mothers giving childbirth and right after childbirth. They also have higher numbers of miscarriage and higher rates of postpartum depression as well. And so it's really important for, as we're serving survivors, right, or even Black moms specifically, that we're really making sure that all of our services are culturally responsive to those needs, that we're really able to go and get extra training, that we're bringing in partners to learn from and to provide higher levels of services to intimate partner violence survivors. There's an amazing organization here in Austin, and it's called Black Mamas ATX. I would highly suggest you guys going and looking it up if you can. They're doing really amazing work here in Central Texas. They have doulas and midwives who are on staff. All of their team are Black, and they all provide holistic services to moms in the Austin and Travis County area. And so if you haven't heard about them, I suggest I'll pop it in the chat box so that you can learn more about them and their organization as well.
I'll chat that in a minute, Amanda, but we have a question from Andrea Simmons, who's introduced herself being with the Fort Peck Tribal Courts in Montana. And she asked if we have some statistics to share regarding Native American women. I can tell you that Amanda and I don't have those statistics in this presentation now, but what we've seen is that the rates for Native American parents are going to be in between those that we've identified it in the general population and in the white population, and then over here with Black mothers specifically. So it's not good. There definitely is, we do have Black mothers over here on the far end of the spectrum, but we can find some statistics that are gonna support similarly dire situations for Native American people.
Yeah, thank you for that question. We'll definitely make sure that we add that moving forward. Thank you. Bronwyn, do you want to talk about this slide for us?
Yeah, absolutely. What's nice about this slide, it's just, it's a lot of different ways for people who are visual learners to kind of think about things. So this slide really breaks down all of the different non-fatal outcomes that can happen, as well as fatal outcomes. Because when we talk about maternal mortality and morbidity, it encompasses all of these things. So, death is definitely on the table, unfortunately, whether it be murder or suicide or fatal illness. But there's lots of other things that are non-fatal outcomes. So somebody who's experienced interpersonal violence might suffer from PTSD. Maybe they are at increased risk to have a substance abuse issue. Maybe the stress and anxiety caused by the violence has contributed to an eating disorder. So you can see over here on the right-hand side of the slide, there's all different kinds of ways this can manifest. But the bottom line of the slide is interpersonal violence can affect your health. We know that to be true.
There's this really awesome thing that we have been really kind of diving into a little bit more. And I think we get to it in a couple of slides, but in case we don't, I didn't mean to go for it, I apologize. With these health consequences of family violence, one of the things that we have started adding into our vocabulary are these social determinants of health, and how, as we're partnering with people in the healthcare profession, it really is important for when people are talking to us that they use our language, when we're talking to them that we use their language. And these social determinants of health are really important as we're looking at the ripple effect that trauma and that abuse causes on all of these other different areas of our life, on our mental health, on our physical health, on our, with substance abuse and depression and our mental health. There's really detrimental effects of intimate partner violence and trauma in general within our whole body. There's a wonderful book, and it's called How the Body Keeps Score. If you haven't read it, I strongly suggest you read it, because it really talks about when we have unhealed trauma and undealt with trauma, how that comes out later in life. Okay, again, more statistics: violence against women, health impact. women who are exposed to intimate partner violence are going to be higher. There's going to be higher rates of depression and alcohol. There's going to be more likelihood that they have a low birth weight, that they have preterm labor. They're at increased risk for HIV and other types of STIs. We see that 42% of women who experience physical or sexual violence at the hands of their partner also experience injuries as a result. I mean, we see all of these different things as a result of violence against women. So the ripple effect on violence against women on our economy is even huge as well. Okay, so we've addressed all of the statistics or some of the statistics on why is this important? Why do we need to partner with our healthcare partners? So one of the things that Bronwyn and I get really jazzed up about is talking about what a medical legal partnership is. And we want to kind of introduce this model to you if you haven't been introduced to it before, to figure out how attorneys and legal advocates can come alongside healthcare professionals and healthcare practices to provide a higher level of service to victims of intimate partner violence.
Yeah, and medical legal partnerships are used across the country in a variety of situations. And the idea that they could be used to help with the intersection between health and intimate partner violence is kind of niche. It's a little more narrow, but I think it's one of the most compelling uses.
Awesome. So social determinants of health. I just started talking about this, so yay, it's here. So what the research shows is that 60% of a person's health is actually determined by these social factors. So what are social factors? Your health insurance, your access to health insurance, what is your income, your housing and your utilities, your education, your employment, your legal status, and then your personal and family stability. 60% of your health comes from these social factors. So sorry, go ahead, Bronwyn. I heard that you want to say something.
You're like, I heard you take a deep breath. So one thing Amanda and I have talked about before is if you imagine a situation where a survivor is unable to work because the abuser won't let them work outside the home, maybe that's one of the ways their abuser controls them. If they're not able to work, maybe they're not able to access income and health insurance to take care of their health. They might also in that situation be unsafe at home, more likely to experience stress, anxiety, physical injury. It's easy to see how the emotional or physical abuse can affect somebody's physical and mental health. It's going to decline. So social determinants of health applies to all people, but you see how it's so compelling when we're looking at it regarding intimate partner violence.
Yeah, what's really interesting is that when any of us have really sat on trainings with healthcare professionals and they're talking about social determinants of health, they really don't focus in or hone in on intimate partner violence within this model. And obviously, because this is our profession, we think of all of the different implications, all of the ways that the victims that we serve are at an increased risk for these types of health issues because of these social determinants of health or their lack of access to these types of social factors.
Yeah, when healthcare professionals look at what they call health harming legal needs, like what are your health harming legal needs? They might think about a veteran who's not able to access their benefits. They need a lawyer. That's a health harming legal need. They might think of somebody with a disability who's not able to, get disability funds, who isn't able to get reasonable accommodations, that they need a lawyer. That's a health harming legal need. There's all kinds of things related to healthcare, housing, things like that, poverty, but domestic violence is one of them. It's a big health harming legal need. The other thing that sets domestic violence apart from maybe being a veteran or being disabled is that we feel that for someone to disclose abuse, it's very likely that they need to feel safe to do so. And while you might be proud to tell someone you're a veteran, or with many disabilities, somebody might see it, whether you're proud to share it or you want to keep it private. With, although a lot of disabilities are secret, we know with domestic violence, it's often secret. So with so many of these, it's important to build that rapport like you might build with your doctor or healthcare professional.
And so because of this, this is really where we look at this medical legal partnership, where we have a healthcare delivery model that integrates. And the level of integration is what we're about to go into in the next few slides. And I'll let Bronwyn kind of explain the different levels of integration. But when we see that the healthcare model and the healthcare professionals really reach into the community to access that and integrate that legal assistance, it can really play a vital role in long-term patient care and positive health outcomes. Okay, Bronwyn, do you want to talk about the referral process and kind of what that looks like?
Yeah, I'd be happy to. Thank you. So, I think we all kind of understand that it's important for the medical community, the legal community, all of us in the movement really to work more closely together. What can that look like? There's a lot of different ways that could look like. Really, the most basic way to start to integrating these two things would be a strong referral stream. So you just need that medical partner to be making referrals over to a legal service partner like Texas Advocacy Project, or even those of you who work in advocacy to make that referral over. So easier said than done. What we've learned is for that to happen, the medical partners need to have training on how to screen for these health harming legal needs so that they know what they're looking for, how to find it, and then what's appropriate to refer over to their partner. So that screening becomes really important. I also want to emphasize a really, really healthy medical legal partnership is a lot more than just a referral stream. So for a really healthy medical legal partnership, a fully integrated one would be for the legal partners to be co-located, to be housed with the medical partner. So just like you would refer to somebody, oh, okay, you've been injured, I'm going to send you to radiology downstairs to have them look at your x-ray. I'm going to send you over to the pharmacy to get some pain medication. I'm going to send you over here to the lawyer to talk about why you weren't safe at home and what your options are. To be fully integrated is the dream. But, we've got referral streams on one end, we've got fully integrated on the other end. What's in the middle? What's in the middle might be a lot of virtual connections, warm referrals, where medical legal partners and legal partners know each other by name. We know we've met in person, we've met virtually. We can send emails and texts or whatever's the most appropriate way to say, hey, I want to send this one over. Will you call them? They can confirm. Bronwyn's going to call you at 3 o'clock. I know her. She's going to help you. Those really warm referrals and virtual connections can be the future as well.
Yeah, I just kind of had this thought. I don't know if we've mentioned this before, Bronwyn, but it might be good to add to the presentation in the future. But
let's just work while everyone's watching.
This isn't a far-reaching thought, because this is a similar model when we think of like the Justice Center model, where you have everybody co-located that maybe a victim or a victim of crime might need. So you've got your victims assistance people, you probably got your crisis center people. You've really got everybody in one building. That makes it a lot easier and breaks down those barriers for survivors to get the services that they need in a really effective way, right? And so when we're talking about this fully integrated medical legal partnership, it's not really this like big idea. We're already doing it in other spaces. To have an attorney right down the hall can be really helpful. Now, with this fully integrated MLP, again, Bronwyn mentioned, and I think we have it maybe on the next slide, how many different types of healthcare organizations and how far-reaching medical legal partnerships are. These are not 333 health organizations in 46 states specifically identifying intimate partner violence and a medical legal partnership with a domestic violence law firm. Like, that's not what these are. These are for lots of different issues. Bronwyn, can you talk a little bit about the different types of medical legal partnerships that exist out there?
Yeah, medical legal partnerships can really work for any health harming legal needs. So I mentioned a few of them, but veterans issues is definitely one. Disability issues is another, where the legal community and the medical community has come together and they say, look, we're all here to help veterans. Let's help each other more. We're all here to help individuals who have disabilities. Let's work together more closely. So it's no different for interpersonal violence. But another field where medical legal partnerships is really taking off is in pediatrics, because pediatricians are highly trained in how to look for issues related to child abuse. So they look for it, they know how to spot it, they are compelled to make referrals when they do, they know who they're mandated to refer to, but they're also really open to getting legal solutions in there as well. So also, if there's housing issues, doctors might identify, well, your health is because of your home environment. Maybe there's bad air quality, bad water quality. Those are another place where it's real intuitive for people to work together. But with intimate partner violence, it's hard. We really are having to really work to make those connections. And a medical legal partnership is so helpful because it just breaks down a lot of barriers. No longer is the client having to think, well, when am I going to have time to meet with this lawyer? And where am I going to meet with the lawyer? Those questions could be answered. They could say, look, we have a lawyer here every Wednesday. Why don't we make your next appointment on a Wednesday and you can meet right after them? They maybe already have hours, office hours, things like that. It also can close a feedback loop. So instead of just sending a referral and being like, oh, I wonder what happened with it. If it's a regular relationship, it's so easy for the legal partner to come back and say, hey, I met with them. They said they really had to take care of the surgery first. So they wanted to talk to me afterwards. I wanted to have us all be on the same page and in the loop with each other. So that feedback loop can get closed. It also creates an opportunity for something Amanda excels at, is regular training for the medical partner, so that they're staying up to date on the latest laws, the latest trends. It's top of mind for them to make those referrals. That fully integrated medical legal partnership is our goal, and it's our goal for intimate partner violence.
So what we know is that that study showed that when legal expertise and services are used to address social needs, we see all of these different positive examples. We see that people with chronic illnesses are admitted to the hospitals less frequently, that people are actually taking their medication as it's prescribed. Imagine that. People report less stress because they're not stressed because they have to do all of these different things. They're really able to address some of those legal needs that they have because they have an attorney working with them. As a result, our economy sees that less money is spent on healthcare services for people who would otherwise go to an emergency room or go to an urgent care. When they're receiving the types of medical screening and preventative health care, they're not making those drop-ins to the ERs and to the urgent cares as well. Do you have anything you want to add to this one, Bronwyn?
No, and the next slide supports this as well. It's just another way of looking at it that we've borrowed, but there's real, measurable, positive impacts on patients and on society when you have medical legal partnerships. So whichever one of these statistics speaks to you, latch onto it, because this is real and it's documented. It really works.
Yeah, one of the things that Bronwyn really has talked about in the past is for her attorneys, she really wants for her attorneys to practice at the top of their license. And when we have a medical legal partnership in place, it allows for the healthcare professionals to also operate at the top of their license. And when those two come together, it really is able to provide a holistic response to that survivor.
Yeah, I mean, I'm not, obviously, I'm not a doctor, I'm not a nurse, I'm not a social worker. There's a lot of things that I don't have the training to help my clients with. But if I can match up and partner with other professionals, like Amanda and I partner every day, that teamwork means we can both be doing what we're best at, but we can still be wrapping the survivor services. So it's really great when we go out and give trainings to the medical partners as well and say, hey, we're telling you this information, but we're not expecting you to do the legal work. We just want to pique your interest and encourage you to make those referrals and join partnerships with us.
Okay, so now let's dive into some best practices that we've seen, and then that some of our partners, our national partners who've been doing this work for a long time as well, like the Futures Against Violence, have come up with some really awesome best practices.
I thought you were supposed to get us the good sandwiches.
I'm sorry, these are not more exciting. Clinic ran late.
That's okay.
Hey, remember those patient satisfaction scores? They're beginning to matter more and more to the powers that be. And this is awkward, but they asked me to give you some pointers. It's really hard for me because I think you're an amazing clinician and I really respect your work.
No, I appreciate it. I know your scores are always so good. It's a little... Okay. It's frustrating because I'm really conscientious.
I know you are. The patient scoring thing is not as much about medicine. It's about how the patient feels. It's much more simple to have the patient feel connected than you might realize. Like, I really make eye contact on the hard questions. When we first got the tablet, I didn't realize it, but my eyes were always on it, not on the patient. But I started to get slammed on my patient feedback about being too cold. So I started to put it in my lap with my hand over it so I wouldn't get tempted. And I also do this one other thing which is so interesting and it shows up in my surveys.
What's up?
Remember those patient safety cards we're supposed to hand out?
Yes, the 50 million thing we're asked to do that has no real purpose except to check a box. Hey, I'm not bitter.
I used to think it was ridiculous too to hand out the cards, especially with a negative TV screen. Then somebody else mentioned it and I started seeing the results in my surveys.
What were you seeing?
I had patients say they so appreciated having the information anyway. Their body language changes when you give them something. When I was working at another clinic, they did a qualitative study asking the providers about how their patients responded when they were given the cards. And all the providers almost unanimously used the same word. They said their patients felt empowered. When I talk about the fact that I hand out the cards to all our patients so they can help a friend or someone in their family, they all say thank you and mean it. Like today, I had someone with a negative DV screen, but I gave her the card anyway. She clearly got a little emotional and said she was worried about her sister. Now, was it her sister or was it really for her and she didn't feel safe disclosing that today? The cool thing is, it really doesn't matter. She got the information either way.
Okay, Obi-Wan. That was good. I was blowing off the cards, not realizing that they get us to the win either way. We so rarely get positives on our DV screening forms, it's easy to forget that there must be lots of folks who don't or can't disclose.
Exactly.
Thank you.
You're buying lunch next time.
Thank you for sharing that. Amanda, somebody chatted that it was difficult to hear. So I'm going to share the link to that video so people can watch it later. It's a great video showing, it's like a sketch between two doctors about why it's important to screen. And it's also, of course, in the PowerPoint that you're going to get.
I don't know about y'all, but every time I watch that, I'm like, I need to go get some green grapes because those grapes look delicious. But maybe I'm just hungry. Also, one of the things that I really want for us to think about is this universal screening. Bronwyn, I want to let her kind of speak a little bit more because we've had some really amazing law students out of Stanford Law School with their Community Health Access Project, who's been doing some legal research for us around universal screening and universal education when it comes to intimate partner violence. And as my team is working to train healthcare professionals across the state, this is one of the models that we look to. I will ask the healthcare partners let me see your screening tools. And for some of those places, it's just a box that says, are you safe in your home? Or do you feel like is your partner abusing you? And for others, it is a full screening packet. And I'll give you some of those resources here in a minute, but I want to give Bronwyn the opportunity to really talk about some of the findings that these law students that are working with us have found.
Yes, the volunteers that we have from Stanford Law have looked at all 50 states and our territories and everywhere in between, and tried to find model policies and legislation related to this intersection between health and intimate partner violence. We have a cross section up here of samples to show you of just all different kinds of ways this could look. And what those students are working on now is drafting, based on the best of everybody, some model legislation that we will then be able to share with everyone who wants to improve the laws in their area. So one of the good things from California is they have a law that says that each medical facility has to adopt a universal screening. They don't say exactly what it should say. They say you need to kind of look at what the American Medical Association has distributed, but that's the way that they do universal screening. So universal screening is when everyone that comes into the medical facility, every adult needs to be asked questions about, are you safe at home? And it needs to be more than that, ideally. Just asking, are you safe at home is usually not enough. So it's a pretty expansive law. It's really general, but it's really just about asking the questions and identifying the patients, pretty general. So there's other states where they try to get close to universal screening. Illinois is one of them. They've asked that licensed hospitals need to have a way to screen. So it's not as broad as California, where it's really almost everybody has to do the screening. We've also read that in Ohio, they have specific protocols. Once they've identified that somebody's a victim of interpersonal violence, they have specific protocols on how you're meant to interview them. Mainly that needs to be in a private place, things like that. So that's a nice best practice that they have those mandates. Here in Texas, we kind of went in a different direction. We have policies in our state that when a healthcare provider suspects that somebody's experienced interpersonal violence, they have information, very specific information they need to convey. It's actually written out exactly what they want them to say. So we at TAP have printed out little cards with that substantially similar language and given it to healthcare providers. So if they identify somebody, they can hand out the card. It basically says like, what you're experiencing is not okay. It is a crime. You have a right to report it. If you need help, you can call this resource, and we recommend TAP, but you know, it says they need to refer them to some resource. So Texas does not require universal screening, but they do require this universal warning if you suspect somebody's experienced interpersonal violence. So it's interesting how all the different states have gone in different directions. New York is currently our favorite because they have really raised the bar. Not only do they have screening, they also have universal education, which really set them apart. So what they do is that every single healthcare facility has to be providing this education to anyone who's in the maternity and newborn wards or getting services related to the maternity services or newborn services. So this is education about how healthy relationships are based on respect, that interpersonal violence is not part of a healthy relationship, that there's laws to protect you. One thing that's good about giving this information out to everyone is even if you don't identify who might need it, you're not going to miss anybody. So that's nice. Another thing is, you know, sometimes giving a card like this out, if an abuser spots it, it could be very triggering. So if you just say, hey, this is our policy, we give it to everyone, men, women, everybody, it's just something we share, that can be a little less problematic. So New York is something we like. There's some other places that are doing different things. Michigan is trying to create a policy of screening all pregnant people. They're trying to screen, this is another one where they're going to screen everyone who's seeking an abortion to see if they were somebody who's experienced reproductive coercion. there's a lot of different ways to look at this. So stay tuned. We've got some great research already, but we're hoping to have some actionable resources soon.
Yeah, I realized just now, Bronwyn, that I haven't told my story about when we gave birth to our daughter. So literally yesterday, Bronwyn and my daughter celebrated her 5th birthday yesterday. Bronwyn's daughter was born a day before my daughter, but we were in the same hospital. Literally on my Facebook today was the picture of the girls meeting each other for the first time when they were like less than a day old, which was amazing. But you know, when I was in the hospital, I was really grateful. I had a doula and I had a midwife, and they were really amazing. And I had a really great relationship with both of them. And then I go to the hospital to have my daughter, and I'm in the labor and delivery room, and like in active labor. And a nurse from the hospital walks in, and, you know, you have to do all these like pre-screening questions and fill out your paperwork before you get to the hospital. So they don't have to ask you a lot whenever you get there, but they still have to ask you some questions. And so the nurse looks at me and she's asking me a list of questions, and she gets to does your partner abuse you, or do you feel safe at home? And I'm like mid contraction. And I just look at her and enthusiastically say, "Oh my God, thank you so much for asking me this question." And my husband's just like, "Lord Jesus, this is not the time, Amanda. This is not an education moment. But for me, this is my life's work." So it really was. And I was like, and she kind of looked at me baffled, like, okay, so is that a no? Do you not feel safe at home? And I was like, "Oh no, yeah. I feel safe. This is my husband. We're great." But like, what would you have done if I said no? I'm not safe at home. My husband is abusing me, but he's sitting right here. And then I was like, okay, no, I'm sorry. I've got to get back to what we're here for, what the intention is here for. We'll talk about this later. Of course, we did not talk about it later, because then a couple of hours later, I had a beautiful baby girl. And then that's all that I could think about. But it was in that moment that I realized, man, I wonder how many times somebody may have these universal screening questions that are in place. Or maybe they really do have a fantastic policy that says we're going to ask you these questions, but there's not the follow through of the best practice and when is the best time to ask those questions, making sure that maybe a possible abusive partner is not in the room. If somebody says yes, what's the follow up to that? So we're going to give you some real tangible examples of how to incorporate these types of policies in. And again, that's something that we love doing when we go and start partnering with healthcare professionals, is really helping them to look at ways that they're providing these services and this screening, and looking at it from a trauma-informed and victim-centered lens, to make sure that they're doing it in the safest way possible.
Nana, we have a question in the Q&A box from Joshua asking about how community health workers and community health navigators and promotoras can work to be involved in screening. I was going to share some information from the National Medical Legal Partnership Group about approaches that involve more community health centers, because I think that individuals like that can be so key to this, because they build that rapport.
Yeah, for sure. You know, one of the things that we see, and at the very beginning of our like dabbling into this medical legal partnership work, Bronwyn and I were having meetings with like the doctors, or the doctors over an entire clinic, which were really great and fruitful conversations. But then what we kept seeing happening was the doctors were like, "Oh, this is really great information. I'm going to give it to our social worker, or I'm going to give it to our community health worker." And we were like, "Why? Like, but you need to know this also, right?" And then we realized, oh no, that is in a lot of spaces that natural referral stream for the healthcare practitioner, for the doctor, is to utilize those social workers and those community health workers. And in a lot of times we see, like, for example, in a community clinic, your nurses, your social workers, your community healthcare workers might actually be the ones that have more contact with patients who might also be survivors, right? So as I'm thinking of all of the doctor's appointments that I went to my OB-GYN whenever I was pregnant, right? There's a billion of them. the people who I had the strongest relationship with were my midwife and my nurse. And so looking at the model, if you're a community healthcare worker within a community clinic, is how are you accessing in, like, what is your access in the community? Where are you going to have health fairs and referrals and all of that kinds of stuff, and building those relationships with organizations like Texas Advocacy Project and with the local domestic violence organization. So you become on a first name basis with one another, because like Bronwyn mentioned earlier, that warm referral stream is really the best practice. And so if I know you and you know me, then it's going to be a lot easier for us to refer back to one another, and for our patients to know that that we're a trusted source. Do you have anything you want to add to that, Bronwyn?
No, I think you guys you're sounding interested, you're sounding curious. These next couple slides really talk about more details about screening. We have this slide from the World Health Organization, a national health body, and then the next slide from the Centers for Disease Control, which is our national health body. So both of these sites have recommendations for what screening can look like. This list is nice, but on the next slide with the CDC, can share a link. They have every kind of example, specific examples of all different screening tools. So no matter what your network is like, there's probably a screening tool there that's right for you.
Yeah, one of the really awesome things about this CDC guide, and the link is here, and again, we're going to share that presentation with you, is they really go, I mean, not even just in the United States, they don't even just look at the screening tools for intimate partner violence and sexual violence within the United States. They really went worldwide. So what are other countries doing, and what are their best practices, and how do they implement these tools? And they did this really in-depth research study about each tool that is available, and is it effective, and ways that it's been implemented before in effective ways. So Jacqueline Campbell's model, the danger assessment, is actually one of the tools that they've studied. If you've been in this work for any amount of time, that might be the tool that your organization uses. I know that all of our social workers and my entire team is certified in the danger assessment, so that we're able to really assess the survivors that come to our services and the lethality that they might be facing, or the level of danger that they might be in. We know that none of these tools are going to be the end all be all, because we cannot 100% anticipate people's abusive tendencies or their danger, because we can't predict human behavior all the time, right? And so these are just guides to what could be implemented. When we go back, I'm going to go back a slide just for a second. When we look at what the WHO has really kind of laid out, is it's not just one thing. It's really saying, hey, your healthcare professionals need to be trained. That's what we at Texas Advocate, that's our first thing that we do. And we don't just give them one training. We have a whole 6-pack of training that includes, what are the dynamics of these types of abuse? How much, like, what are the red flags to look for in your patients? And then we go into what are the screenings? I do an entire presentation on screening tools specifically. And then now what? Now what do you do? How do you implement all of these best practices into your model? Because every healthcare practitioner has a different model, different policies, different procedures. And so you have to figure out what's going to work for your agency. And going back to that universal screening, what are you going to be able to implement in a universal screening process? We don't want you to say, gold standard, we're going to do this really amazing screening tool. We're going to do it to every person, and we're going to have this whole packet of information. We're going to give it to every single person. And then for about 6 months, you do that, and then it kind of fizzles out, right? Because maybe you have new healthcare professionals who are coming into your clinic, because healthcare workers right now are getting burnt out, right? And they're leaving at really high rates. And so really looking at what can you implement for the long term? That's going to be the most helpful. One of the really important things, and healthcare professionals have been doing this for years, is that confidentiality is key, right? Like, they know that we got lots of HIPAA standards and all of the things, but we want to take this a step further. When are you screening, and making sure that those consultations are in private settings? Maybe they're not in a private setting. Maybe it's in a regular, doctor's office room, and you might have an abusive partner that's in there, and you have to send that potential victim down to get blood work, right? So then you're sending them to a different thing, and the abuser can't go with them. They have to stay in the room. come up with some type of way to say, oh yeah, sorry, because of COVID, I don't know, you can blame anything on COVID now, that only one person is allowed in this room at a time. That allows for you to be able to have an open and hopefully honest dialogue and share some resources with those potential survivors. Okay, I'm going to skip past that one. Okay, so how can healthcare providers support a survivor? We kind of talked about this. We're going to the best way to do this is by integrating these services into their healthcare services, that they're documenting it. Every state is going to be different in what your mandatory reporting requirements are. We've had this issue in Texas specifically that has come up when I was working during the legislative sessions with our state coalition. We would have healthcare, medical people, sorry, that's not the right term, healthcare professionals, reach out to us and say, hey, we really want a law passed this session that says, if there's somebody who's been abused by their partner, that's a mandatory report, similar to what we see for potential child abuse, right? And everybody's a mandatory reporter for child abuse. And there's been healthcare practitioners who have wanted it to be for domestic violence to be put in that category. We know in this field that is not a best practice. And we really strongly advocate against that, because at the end of the day, it's really important for the survivor to have agency in their own healing and in their own reporting. And it might not be safe for survivors to report the abuse that they have faced, because it could put them in future danger. And the only person that's going to know that is the survivor. They're going to be the expert in their own safety. So I can give survivors information all day long. And I hope that one time, whenever they come and intersect with services that either we are providing or somebody who we've trained has provided, that's something they'll get that information some way and they'll reach out for help when they need it. But I really strongly advocate against a mandatory reporting of domestic violence within the healthcare field. You want to add anything to that, Bronwyn?
I think this is great. They've tried to bottom line it. So the WHO has these 6 things you got to have. But Amanda has noticed one they don't have. If you go to the next slide, it's so key that they should have added safety planning to that. So please do the 6 things the WHO says, but you need to add what Amanda says, safety planning.
So what we know is that recognition and validation of a survivor's experience is really a critical step whenever we're working with survivors. And specifically with healthcare providers, what we know is that when women disclose that they have been or are in an abusive relationship, and that healthcare practitioner can kind of close their laptop and sit back and connect with that patient and validate their experiences, that those victims are actually going to be 2.6 times more likely to exit that abusive relationship. That is a really powerful thing. That is a lot of power that one person in our field can have. And so the validation of it, the recognition of it, moving past just the screening of it, and then really being able to safety plan with that survivor. We know that leaving, right in the process of leaving and right after a victim has left an abusive relationship, is the most dangerous time. And I want to be on the phone with a survivor to help make sure that we can really holistically look at all of the safety included. Maybe that's technology, maybe it's their kids' technology, maybe it's trying to get them into safe housing and long-term safe housing, all of these types of things. Those are things that my team is able to do. These are things that I'm training the social workers that are embedded within hospital systems. The safety planning is something that they should be able to do as well. So if you're a healthcare worker or you are working with healthcare professionals, make sure that this is part built into the training that you're doing with them, is what are the action steps that they can do? What can they say? And the safety planning tips that they can provide to those survivors who might end up going back into that relationship for the evening, right? But like part of a long-term escape plan would be, that recognition and validation is really important. Okay, we have another video again from our friends at the Futures Without Violence. This is a way for you to incorporate some universal education into your practice.
Amanda, make sure you're doing the share volume.
Couple of things today.
Can you hear it?
We've started giving all of our
I
clients
can,
this
yes.
Healthy Moms,
Okay.
Happy Babies card. It's kind of like a magazine quiz.
Okay.
So it talks about healthy relationships, ones that aren't, and how your relationship can affect your parenting and your health. So it also describes a safety plan on there, you know, what to do if a partner was hurting you, has hotline numbers to call, all that kind of stuff. So it kind of serves two purposes. One is so that moms have the information for themselves in case they'd ever need it. The other is so that you have the information to pass on to help a friend or family member if you're worried about their relationship.
Thank you. This is good.
I really think it asks a lot of good questions. I like that it talks about good relationships and what folks really deserve. It also reviews what a lot of women deal with, being hurt or afraid of a partner.
I guess that happens a lot.
It does. And one of the things we know for kids is if something like that is happening to mom, it can really affect them. It can affect their health and development, how well they do in school, all that stuff.
Yeah, that makes sense.
So this tool here is just something to help get a sense of where things are in your relationship. It looks at your partner's actions and just gets a sense of where things are and how it's going with you too. It only takes a few minutes to fill out.
What do you do with the information?
Oh, we just keep it as part of our internal records so that we can keep track of how often we talk to moms about their relationships. You can see right here on the top of the form, it explains that we don't report any positive findings on this to anyone. The only thing we do have to report is known or suspected child abuse. But other than that, we don't share any information about your relationship to anyone outside of that issue.
Okay.
Okay. So let's move on to our medical legal partnership initiative, what we've done at Texas Advocacy Project, and then ways that you can implement this into maybe your practice, or ways that we can come and help partner with you in whatever area that you're in. So there's really two critical parts. So the first part is what my team does, and the second part is where Bronwyn comes in. And so the first part is the outreach and the training. You've heard us talk a couple of times throughout this presentation about as we've identified partners that we think would be good, maybe these are organizations like community health workers or community health clinics. And we've identified those partners, and then we ask if they would be interested in like a 6-pack of training. And that 6-pack of training is really can be individualized to the needs of that clinic specifically, but in general, it includes what are the dynamics of intimate partner violence, how to safety plan with survivors, looking at screening tools that are available, and then really coming up with an action plan for their clinic is kind of what that 6-pack of training looks like. And then as far as the legal services go, I'll let Bronwyn talk about those a little bit more.
Yeah, thanks. I love that, you know, when we talk about medical legal partnerships with medical partners, integrating with legal partners, that in our own agency, we've been really working to be more integrated and more collaborative between these different arms. So as far as the legal services that we provide, whenever we are talking to one of our clients, part of the job of the lawyer in a consultation is to issue spot. What are all the different things this person needs help with? And traditionally we look for legal issues they need help with, but something we're definitely trying to do more is to look for those social issues as well. And when we see them, to make referrals to our social worker at our agency and try to help them in that way. So Amanda, in her outreach work, has created these referral forms that we can receive from medical partners. Right there, we can see who they're working with at the agency, who sent the referral over. We can see what they think they might need help with. We can reach out to them right away. We can get them same day, next day, or very soon set up with a consultation where we can do that assessment. What are all the medical issues they need help with? We definitely want to talk about the one they were possibly referred to us for, but we always assess everyone for safety issues first, and then any of these other legal needs we might be able to have. So the fact that we're able to get to them so quickly, we get their permission to update the person who referred them when it's appropriate. We issue spot for anything that they might need help with, and we make sure that they're being seen as a whole person, that we're caring for all their needs. That's what we call VIP TLC. So we make sure to really have that elevated level of service, that timeliness, the quality of services, and that integrated work with other partners.
Yeah, that's really great. One of the, I mean, and even in addition to that, after we've, created these individualized reforms, we might be having referrals going back and forth. Again, we want there to be continued education for the healthcare practitioners, but then also for us too, because there might be really awesome trainings that those healthcare professionals, they usually have some type of education team as well that they can provide to our attorneys and to our social workers to really make sure that there's like a cross referral system happening. That's like, again, that part of that integration model is really great, but continued collaboration, we really need to be making sure we're touching base, that we're, one of the things that we did this last year was Health Cares About Domestic Violence Day. What's your agency doing to help elevate your work within the healthcare field and reaching into the healthcare systems and honoring them? So we sent cookies to all of our healthcare partners. Bronwyn took them lunch. We've sent them flowers. Like, we want to make sure that we stay at top of mind. And part of that outreach effort is that even if maybe referrals have slowed down, that we make sure that they know that we're still there.
Absolutely.
Okay,
so I mentioned just now that we're screening all of the patient clients that come to us for any kind of legal need. And I want to give you some examples. This isn't meant to be like some legal education for you, but I just want to show you all the different ways that health harming legal needs could present in a healthcare practice. And then what solutions TAP might provide to those health harming legal needs. So one example would be safety. This might be the most basic presentation you could think of. Let's say a victim of domestic violence is not safe from an abuser. We can help with that. They're at the emergency room, they've been assaulted. That's a typical, stereotypical example people would think of. TAP can help with that. We can help somebody get a protective order to try to keep their abuser away from them. But there's a lot more we can do than just a protective order. Under privacy, for example, let's say that a young person has had a nude photo they've taken or they've sexted, it's been shared, and now they're having suicidal ideations. This is such a common example. TAP can help with that. We can help them get an injunction to prevent revenge pornography from occurring. Look at employment, for example. Let's say that there is a patient who's experienced sexual harassment and now they've been fired, so they no longer have their health insurance. We can help with that. Texas Advocacy Project has solutions to those problems. We can help get them coverage in situations like that. Under family law, let's say someone is receiving prenatal services, maybe they're pregnant because they've been raped, they were sexually assaulted, and they're worried about their rapist having access to this child. TAP can help with that. We can help terminate a rapist's rights so that that's no longer a concern for that patient. Under criminal justice, for example, maybe a victim of some kind of child abuse, maybe their parent is having to miss work to take them to the doctor, to take them to the police station. We can help with that. Texas Advocacy Project can help that parent access something called crime victims compensation to pay them for their lost wages as they're supporting a young person. I know this is a lot, guys, but I'm halfway done. Under education, maybe there's a patient who is, they're showing signs of an eating disorder. Maybe they've been bullied at school and it's affecting them, and now they have some kind of eating disorder they're going to the doctor for. We can help with that. Texas Advocacy Project can help people get a stay away agreement to prevent bullying from occurring. We can help with accommodations at the school, things like that. What about housing? Maybe someone who's been sexually assaulted is getting medical treatment after a sexual assault, and they don't feel safe going home. They don't want to go back to the house or apartment they were sexually assaulted in. We can help with that. We can help someone like that terminate their lease so they no longer, and they won't have any financial consequences for terminating that lease. There's also financial things we can help with. Let's say that there's two parents who are co-parenting and the abusive parent isn't paying for their half of uninsured medical expenses. This is like one of the only ways they can still try to have parent control over their victim after separation. It's through the children. We can help with that. Texas Advocacy Project can try to garnish their wages to get the money they need to pay the medical bills, pay the pediatrician, things like that. And finally, I have on here civil liability. Let's say a victim or patient is getting treated for their injuries. They might have a personal injury claim against their abuser, and Texas Advocacy Project can help with that, help compensate for those medical injuries, and sometimes emotional damage as well can be part of that. So the bottom line here is there are legal solutions to all kinds of medical problems. And all of those issues that you see in front of you are things that TAP will always issue spot for. It's not the responsibility of the healthcare provider. This is what Amanda meant by saying we practice at the top of our license. So the healthcare providers, they're helping people with the medical problems. And if they refer to us, we will help with those legal solutions that can help solve the problem. So we'll help to screen them for eligibility. We do all of that. All they have to do is connect with us.
Awesome. Thank you so much, Bronwyn. This is like the heavy hitting slide of the entire presentation because you have to go through all of them. So I'm going to let her take a breath after she's done all of that. Here's what we know. Let's bottom line it. When we have really individualized legal care, we know that that's going to improve the health of the survivors that we're serving and the wellness that they have. When we're able to offer free legal assistance, that is such a huge part of reducing stress for a lot of victims of intimate partner violence. It can, when you think of hiring an attorney, that can feel really daunting. It's associated with a really high cost, with long wait lists, with, just think of all of the movies that you've watched with attorneys. For the Texas Advocacy Project, all of our attorneys on staff are specially trained and work with victims of these types of crime every single day. So they are able to issue spot, like Bronwyn said on the previous slide, and they're able to kind of foresee how an abuser might try to utilize a criminal justice system or utilize a healthcare system against that victim. And they're able to provide really individualized legal solutions for those survivors. So that's going to reduce that stress. Our attorneys can help with divorce. This can really help close a chapter. It can also provide financial support. It can also provide really clear instructions on when and how an abuser can access children, and safe ways for them to access children, and safe ways for that victim to receive communication from that abusive parent. Protective orders. This is one of the, Bronwyn has some statistics around it. I'll let you throw those out there in a second about how effective protective orders are at stopping abuse from happening in the future. Do you remember what those statistics are, Bronwyn?
Yeah, my favorite statistics on this are old, but they're from the Journal of the American Medical Association, believe it or not. And JAMA did research and they found that protective orders can be as much as 80% effective in preventing future violence. So that means that in 80% of cases where somebody's gotten a protective order, there's not going to be another issue. That's not 100%, but it's actually what they found, the best intervention we had. It was more effective than wearing a wig, changing your name, going into hiding, even going to a shelter. All of that might be part of your individualized safety plan. But getting protective orders is a good thing to consider. They're not right for everybody, but they're very effective. The more recent study we have is out of Kentucky. I don't love that statistic as much, but coincidentally, it's also, I think it says an 80. It talks about how in 80% of cases where there was no more violence, the applicant for the protective order attributed that to the fact that they had gotten the protective order. So it's more self-reported. It's a little, not as strong, a little looser, but bottom line, they're good. Not for everybody, not 100% effective, but they're more effective than people think.
Thank you. And then safety planning. When we're able to safety plan with survivors, we know that that's going to reduce the risk that they face and also that their children face. Okay, we've got about 10 more minutes and I want to make sure that we save time for some question and answers at the end. If you're interested in reading more about what our work is at Texas Advocacy Project, we've been featured in a couple of journals, the Texas Family Physicians Journal. We've had a blog as well, a blog post that was at the beginning of the pandemic that we wrote. And then here's Bronwyn and my contact information. We want to be a resource for you. And then also our legal line number is here at the bottom, which is 800-374-HOPE. 800-374-HOPE. You can tell survivors to go there, to call if they're interested in or needing legal services. They can also go to our website at texasadvocacyproject.org. And there they can apply for services directly online. Again, part of your safety plan, is it safe for them to, access filling out that application for services on a computer that might be monitored. But if not, also, we want to be a direct referral source for you. So please reach out to either of us. Okay, we've reached the end of our presentation.
Yeah, I've been monitoring the chat, Amanda, and with some reminders, I've been monitoring the Q&A box. So I think we're up to date right now. So if I missed you for some reason, please point it out. But otherwise, we'd welcome any other additional questions. We'd also love to hear if any of you all have experience with medical legal partnerships, please share. I can see that Catherine has shared that she's a former emergency department and trauma nurse. So she has experience with injury and violence prevention. So there's a good contact for people. But anyone else who has experience with this, we'd love you to chime in. She also mentioned a medical power and control wheel. So I shared that link. If you guys want to read about that more, that's not something that we had in our presentation, but I think we should consider adding it.
Don't lose it. I'll add it to the 15 things that I have open on my.
Yeah, it gets better every time we hear more from people. Well, please share your questions. Also, little commercial, Texas Advocacy Project would love to partner with you. So that contact information we had up, will get shared with you. We really would love to partner with you. Otherwise, I think you'll be getting a survey link to evaluate the presentation.
Thank y'all so much for joining us. This was really helpful, so many tangible takeaways, and I really appreciate our attendees for being so active and engaged throughout the webinar. We're also going to be posting this webinar on our website under our resources page. So if you have coworkers or partners in your community that this would be useful for, please feel free to share that link with them. And like Bronwyn mentioned, you will receive the evaluation, the recording, and handouts within 24 hours from today's webinar. So keep an eye out for that. Once you complete the evaluation, you'll receive your training certificate, which you can use for accreditation if you need that. And I see that Stephanie Love Patterson mentioned that Chicago's Stroger Hospital has a wonderful partnership since 1992, where services are incorporated into the fabric of our hospital. I love hearing that. It's so great seeing the progress that healthcare organizations and advocates are making in their relationships across the state. So thank you, Bronwyn and Amanda, for all that y'all do to help us advance in this work. And thank you, attendees, for joining our last webinar of 2021. I hope everyone has a wonderful holiday season, and hopefully we'll see y'all again in 2022. Bye, everyone. Thank you.